Hi, this is Dr. Clayton Moliver. Welcome to my vlog, Symmastia. Well, if you've gotten to this vlog, you probably already know what it is. Symmastia is known as Uniboob, or one breast. It can be congenital. Some women are just unfortunately born that way. And I see women come in all the time who have the sternal skin lifted up, particularly in large-breasted women. When we talk about Symmastia in this setting, we're talking about the lady that had a breast augmentation and the skin in the middle lifts up. It's either lifted up all the time or it's lifted up when she brings her breasts together in a bra. It's up to the plastic surgeon to determine which type it is, but it's repairable in most cases. In the past, we had to use sutures to tie down these muscles here. Most breast Symmastia cases, in my experience, and in the literature suggest this, is after a breast augmentation under the muscle. There's reason to believe that it might be because of muscular imbalances and which muscles were lifted up during the operation. And I'm doing some studies on that right now to determine if that's in fact the case. I believe it is. When I repair Symmastia, I usually use Belladerm, made by MTF Company out of New Jersey. Most of us are using ADM, or acellular dermal matrix material, which is human dermis that's been treated to protect you from any biologic viruses or agents. And we sew it like an internal bra underneath the breast and up medially to secure the implants so they stop drifting across the midline. Then, if the skin's lifted up also, we have to address that. Sometimes suction catheters will allow that skin to set down. I've been using tissue glue lately with great result. So with a combination of tissue glue, some suturing all along here, and the acellular dermal matrix, we can fix most cases of Symmastia. A lot of the Symmastia literature talks about many cases being under the muscle, and we found that to be true. What I found in my practice is that many times it's a displaced implant. And Symmastia sometimes happens unilaterally, and really it's not Symmastia anymore, it's malposition of the implant. If it happens on both sides, it turns into Symmastia. Many times I'm finding that the pectoralis minor muscle, the major and the minor, has been inadvertently lifted up. And this muscle pushes the implant medially. I found this in a number of cases, and we're doing some research now to determine how often this happens. Intraoperatively, I've treated it many times by releasing the pectoralis minor and putting it back down, or just cutting across it up here so it's not functional anymore. Many of these patients will tell me that they've had a previous surgery or two to get that implant to slide laterally. The plastic surgeon will have opened up the pocket laterally, and the funny thing is that when these patients lay down, the implants slide out laterally, and when they stand up, the implant moves in, and they have that same problem again. And you can demonstrate the pectoralis minor actually pushing the implant in. It's a very interesting finding, and I hope to publish some more information on that soon. Thanks for visiting my vlog. This has been Dr. Clayton Moliver. If you want to explore plastic surgery, please give us a call at 281-282-9555. You can Skype video conference with me at Doc Moliver, or you can reach us on the web at drmoliver.com.